I will state that, we had stated originally that Dr. Rodriguez was going to join us, but he is tied up in, I believe, the lab or clinic, and is probably not going to be stopping over. If he does, it might be for a very short moment just to introduce himself to you all. So we'll see how that goes. Okay. All right, Jeannie, you're on.
Thank you. So we'll go ahead and get started. Thanks, Dr. Scott Tillery, for agreeing to give us a talk on some cardiac concerns. I think you presented here before, or I heard you at one of the Billings Clinic CMEs that was held, and it was great. She always does a really great job. She did her internship in Rhode Island and residency in Rhode Island. She did a cardiac fellowship at Barnes Jewish Hospital in St. Louis, Missouri. She's been at Billings Clinic since 2011, and she's board certified in advanced heart failure and transplant cardiology and also in internal medicine. Welcome, and we're looking forward to your talk today. Thanks.
Hey, thanks, guys. Let me share my screen. Bear with me. Technology is not my strong suit. Okay, can y'all see that?
Yes.
Yeah.
Okay, good. So I do have to say that this is a bit of an ambitious talk. I have a lot of slides. I'm going to not talk about all of them, but you have them for reference. So some of the details on the trials, I don't think we need to talk about today, but we'll definitely have the information in there for you. But what I want to talk about today is a technology that that we're really starting to use a whole lot more. It's something called the Cardiomems device. And I don't know if any of you share a patient with me that has one of these, but this is a really amazing technology. I'll show you how it works and how we implant it and all of that. But I want to start with some background. I don't have any relevant disclosures. So we always like to do things case-based. So I'm going to bring up these two cases. We'll talk about them for a minute, and then we'll bring them back at the end and kind of show you how the Cardiomems helps us with each of these cases. So the first case is a 77-year-old gentleman with an ischemic cardiomyopathy, so reduced ejection fraction of 25%. As you can see, we've done all the stuff we need to do. He has a BIV ICD. He had bypass grafting in '96 and then again in 2002. And we've checked and made sure that they're patent. Importantly, he has chronic systolic congestive heart failure, and he's New York Heart Association Class 3, Stage D. He's had 3 hospital stays with decompensated heart failure, and he's on optimal medical therapy. His other comorbidities, he has RV dysfunction and pulmonary hypertension, atrial fibrillation, kind of your usual stuff. He is on a CPAP, which is nice, and he's got renal insufficiency. So this is basically, that's what our heart failure with reduced ejection fractions look like. He actively follows with us in the heart failure nurses program, which is what we do. We do telemonitoring. So patients call in the morning, and there's a questionnaire, and they type in their symptoms. So are you more short of breath? Yes or no? Are you, is your weight up? And you tell them how many pounds it is. And depending on what you put in, it flags our nurses to call you back. And then what we do is make medication adjustments based on what we're hearing. Okay. Importantly, this gentleman is very compliant. Case 2 is our case of heart failure with preserved ejection fraction. So this is pulmonary sarcoidosis with cardiac involvement. She follows here, and she also follows in Colorado with pulmonary. And she's preserved, and she's very brittle. So this is someone that, every time we turn around, she's in the hospital. She's either super dry or she's, super wet. And it's been very, very difficult to manage her. She was actually our very first Cardiomems implant. She has a BIV. She has CKD stage 3, type 2 diabetes. Again, basically your basic picture of heart failure with preserved ejection fraction. She did have a hospital stay over the last year, and she's New York Heart Association Class 3. Again, she follows with the heart failure nurses. She's compliant, and she's on good medical therapy for heart failure with preserved ejection fraction. So the question of the hour is, how do we keep these patients out of the hospital? And as you know, over the last several years, Medicare has made it very costly for us to have patients in the hospital, and especially patients that get readmitted. So unfortunately, I've kind of been tasked with fixing that for the whole organization. So we're doing our best, but you know, this is a real problem. How do we keep these patients out of the hospital? So I'm going to go through some quick epidemiology because I think it's really important that we realize what we're actually seeing. I mean, everyone knows heart failure is a problem, but the enormity of the problem is kind of shocking. So we're looking at over 8 million cases by 2030, which is a lot of patients. About 1 million hospitalizations a year in the United States for primary heart failure. 50% are readmitted within 6 months. I mean, that is a terrible number. It's even worse when you look at 30-day readmissions because we're getting dinged for them. So we have some data for that coming up. There are almost 100,000 new heart failure cases a year, and it's $30 billion cost per year, that's pretty significant. And it's estimated to be rising by 2030 to $70 billion, which again, I think is why Medicare is getting really up on the ball, trying to make sure that we are bringing these numbers down. But I think the most important thing to state, because patients don't understand this, that there's a 50% mortality rate at 5 years once you get diagnosed with heart failure. I mean, that should be really telling, and that should make patients say, holy smokes, you know, this is like having cancer. It's really serious because patients don't treat this very seriously. You know, they feel bad, they come in, we take some fluid off of them, they feel great, and they go home. But it's not anywhere near as clear in their eyes at how serious the mortality rate is of this disease. So let's look at some demographics. And I think the important take home from this slide is that 1 out of 5 people will develop heart failure. That's a lot of patients. And if you look, men tend to get heart failure earlier in life. Women tend to get it later, but at the end of the day, the mortality risk or the lifetime risk is the same for men and women. And this is just another way to depict that same information. If you look, the blue bars are males and the red bars are females. And so the males start to get heart failure symptoms at about, age 60 to 79, more so, and women more so in their 80s. And I think this is a very telling slide as well. We're getting a lot better at dealing with myocardial infarctions. And if you look, the death rate from coronary disease is declining, but the hospitalizations for heart failure are increasing. So you might say, well, maybe that's because we're keeping these patients alive so that they can develop heart failure later on, whereas before they would just die. And I think there's truth in that. But nonetheless, we're seeing a significant rise in the number of heart failure hospitalizations. If you look at the burden of heart failure, this is a graph I think is pretty telling. The solid line is the projected burden of heart failure cases. This is looking at patients greater than or equal to 65 years of age. And the solid line is a nice, even slope. Still, it gets really high by 2040. But the dotted line is what we're actually seeing. And you can tell that curve has taken a sharp turn. And we are rising way faster than what we were predicting to see. So this is quite a significant burden for us. And if you break this out, I think this is important as well, because I think that people that have heart failure with preserved ejection fraction somehow think that they've kind of escaped the worst, and that, you know, they're going to do fine. But the truth is, this is looking at what the population looks like by ejection fraction. So you can see that it's roughly the same number of patients. It's about 50-50 split between reduced ejection fraction and preserved ejection fraction. But again, women get that late spike in what I call the little old lady heart. So they're small hearts, they're thick hearts, and very stiff. So there are heart failure with preserved ejection fraction that we see later in life. And to that point, if you look at readmissions for heart failure, the red bars are systolic heart failure and the yellow bars are diastolic heart failure. They're roughly the same. If you look at overall, these are all different studies that are looking at it, but overall, they're roughly equivalent. Maybe a little bit more readmissions for systolic heart failure, but diastolic heart failure is pretty much just as important of a problem. I know many of you have seen this slide, but it's something that I have a really difficult time explaining to patients because, again, they come in, they have their acute event, they're functioning very well, right? They have their first event, and as you can see, they come along and then they dip down in their myocardial function. We treat them, we diurese them, you know, give them good medical therapy, and they get better, but they never get better to where they were before. So it's a gradual decline, hospital stay by hospital stay. And it's really hard to get that across to patients because, again, you bring them in broken, you fix them up, they leave and they feel great, but they don't see the fact that they're never quite as good as they were before. Usually they don't see that until 4 or 5 hospitalizations down the road. And at that point, we've missed the boat. So what's the goal of heart failure management? It's to avoid hospital stays for exactly that last slide, for that reason. And so what we try to do is maintain fluid balance and avoid decompensations and avoid hospital stays. So how are we doing that now? And you guys all know this. We talk to patients, we ask them about daily weights, shortness of breath, orthopnea, exercise tolerance. We use our telehealth, calling in on a daily basis. And what we say is, okay, if we start seeing increasing symptoms, increasing symptom burden, then we make medication changes to try and fix that. But that's really without data. That's just kind of, you know, you're telling me you're more short of breath. Well, you know, could you have a COPD exacerbation? I don't know, but let's give you some more Lasix and see if that helps. That's kind of the way we've been doing it. We also look at other things to try and give us information about hemodynamics. So jugular venous pressure tells us about our right atrial pressure. So if it's up, we know our right atrial pressure is up. S3, that's, you know, when the blood is sloshing in. That tells us that our LVEDP is high. You know, we can check BNP, but all of these things we're using these to predict decompensations. Let's see how good we are. So we're not great. If you look at the sensitivity and specificity of all of those things that we normally use, it's pretty terrible. Honestly, if you look at all of it, the thing that gives us the best information, I have to say clinically, is the thing that most people don't do, and that's look at jugular venous pressures. And it's so important to do that. And I'll tell you, you know, when you learned about it in med school, you know, you learn this lay at 30 degrees, use a ruler, all this kind of craziness that's really not accessible at the bedside. So that's not how I do it. What I do is I have the patient sit straight up. If a patient is sitting straight up, the clavicle is about 5 centimeters of water. So if you don't see any jugular venous distension above the clavicle, then you can say the right atrial pressure is less than 5 centimeters of water. If you see their ears bobbing, right, because the JVD is so high that it's bobbing their ears, that's the level of 15 centimeters of water. And so you can use that as a guide. So I don't use rulers and I don't have people that don't adjust the beds and all that. I just have them sit up. So that's giving us a positive predictive value of 60%, still not great, but better, and a negative predictive value of 69%. Because as you all know, there are certain things that you can talk about for things that interfere with jugular venous pressures, right? So if you have severe tricuspid regurgitation, you can't really judge what their jugular venous pressure is because it's flooding back, and what you're seeing is the wave of tricuspid regurgitation and not necessarily their actual JVD. So the question is, are we any good at doing this? And no, we're terrible. We're terrible at using these measures to tell us how people are doing. And, you know, for me, I find this really disconcerting because this is my life. This is what I do. And to know that these are the numbers that we're looking at is really disconcerting. So this is looking at a post hoc analysis of acute decompensated heart failure patients from 2 trials that were run by heart failure doctors. Okay, so this is not you guys running a study. This is actual heart failure specialists running these studies. And with that, at discharge, 40% of patients were still moderate to severely congested. And 60%, had, you know, mild congestion, which is reasonable, but at 60-day follow-up, 41% of those now had severe or partial recongestion. So using the way we're doing it now is not really helpful, and this saddens me. So to go through a few of these trials, I don't want to beat you to death with this, but I want to really let you know that it's not just me saying this. So this is a teleheart failure trial, and this is looking at patients who call in every day with their weight and their symptoms. How does that work for reducing readmissions and reducing death? And, you know, the data shows that it doesn't help at all. There's absolutely no difference in the number of deaths or readmissions in the hospital. And anecdotally, I just have a really hard time believing that. I believe science and I believe the studies, but I see what we do every day and I see the value in what we're doing every day with telemonitoring. But this data really shows me that that it's not enough. Here's another trial showing that weights and blood pressures do not reduce readmission or mortality. So some new things have come out, impedance changes, and that's basically taking an existing device. So you have to already have a device, either a pacemaker or defibrillator, and using the impedance of the device to give you a clue about whether you're getting into trouble and whether we should be making changes to medications. So the example that we're going to use is Optival. There's HeartLogic. There's a whole bunch of different packages like this that are in their devices. And the thought behind it is that if you increase fluid, so if you're getting volume overloaded and you're starting to get in trouble, then your thoracic impedance is going to decline. And you can use it as a guide to say, oh, okay, we're getting in trouble. Maybe we need to increase diuretics. However, what we found is that it did not make any difference in percentage of death. And actually, the ones that had an alert, so there were ones that you could set an audible alert that the patient would hear and say, oh, okay, that means I'm getting in trouble. I better do something. That actually increased hospitalizations. So impedance is not very helpful. Okay, I mean, it's not great at immediate interventions, but it's better than weights alone was the take-home point for impedance. So right now, if you look at what we've got, this is our current strategy. It's super depressing. Looking at everything that we have, looking at impact on hospitalizations for heart failure, nothing is working. I mean, these are good studies. These are not crummy studies. These are good studies. And looking at everything that we do right now, nothing has been helpful. So let's think a little bit about what actually is a CHF exacerbation. I think this is going to make it more clear and understandable about why the Cardiomems is helpful. So as you know, either with left heart failure or right heart failure, can you guys see the little mouse, my mouse?
Yes.
Yes, okay. Okay, that's helpful. Okay, so either with left heart failure or right heart failure, both of those things are going to decrease your cardiac output. When that happens, you're also going to be having an increase in your left atrial pressure from left heart failure or your right atrial pressure from right heart failure. All of these things together, they cause the symptoms that you see, and they cause neurohormonal activation, but they all also have this limb that comes back here and increases pulmonary artery pressures. When you increase pulmonary artery pressures, you keep the cycle going. So it's a vicious cycle, and it's all really being related by pulmonary artery pressures. So why do they rise? And what does it tell us? So the table of truth, the cath lab, let's do a right heart cath. That's my answer to everything. And if you ask my partners that are interventionalists, they will corroborate that. So just really quickly, what are you looking at when you do a right heart cath? So these are the waveforms that you get. I'm not going to school you in hemodynamics today, but I just want you to just be familiar with what we're seeing. So this is right atrial pressure, and it's usually the lowest pressure. Okay, here is your right ventricular pressure, your systolic pressure, and your diastolic pressure. Now, so that's us going into the RV. Now we're going to curve back up and head up into the pulmonary artery. And here is your systolic, and here's your diastolic. And you know that you're in arterial pressure because you have the dicrotic notch here. You have the dicrotic notch here. So these are arterial pressures. And then from the pulmonary artery, you zip on out over here into the pulmonary vasculature, and you get a wedge pressure. And this is your wedge tracing. Okay, it should be higher than the RA. Okay, although they look very similar. The thing I want to point out to you is, and I know when I was in the ICU when I was a resident, the nurses would come up to me and say, "Oh, I can't wedge, so I'm just going to use the PA diastolic. Are you good with that?" And I would just be like, "I have no idea what you're saying." Okay, sure, let's do that. So this is to show you that actually the PA diastolic pressure should be equal to the wedge pressure. And that's important because that's what we're using the Cardiomems to look at and to do. So just to make it easy, the right atrial pressure is CVP. The pulmonary capillary wedge is your filling pressure, your volume status, and the PA diastolic is usually equal to the wedge. That's different if you have primary pulmonary hypertension, but that's for another day. So I think this slide is so important, and I think if you understand this slide, then you get it. So blood flows from high pressure to low pressure. This is just physics. There's nothing special in our body that allows us to defy the laws of physics. So blood flows from high pressure to low pressure. So if your wedge pressure rises, so your wedge pressure is your left atrial pressure, right? So if your left atrial pressure rises, what has to happen to the pulmonary artery pressure? It has to increase, right? Because it has to drain down and fill in the left atrium. And so if the pressure in the left atrium is higher than the pulmonary pressures, blood goes backwards. And so we have this amazing body that tells us, okay, left atrial pressure is rising. So that means total body fluid is rising, volume status is going up. So pulmonary pressure has to go up too. So why is it that they say if a patient is in a decompensated heart failure, don't give them sildenafil, right? Because their PA pressures are going to be high, but if they're in heart failure with high PA pressures, sildenafil will selectively dilate the pulmonary artery and decrease the pulmonary pressures to the point, if you do it enough, to the point that then the left atrial pressure is higher than the pulmonary pressures, and blood flows backwards and fills up your lungs, and it's terrible, and it's respiratory failure. So this is the main the main take-home point of this whole thing. So how do I use that information? This is a graph that's showing you days preceding a hospital stay. So here's where you're going to be hospitalized for a heart failure exacerbation. Here's 30 days before when you're peachy and you're looking great and your pressures are wonderful and everything is happening normally. As you can see, as you're heading towards a hospital stay, you get some filling pressures that start to increase, right? So you're filling up a little, your pulmonary pressures are rising. You fill up a little bit more and you start to get the autonomic changes, the adaptations that your body goes through. A little bit further to the hospital stay, this is where your impedance changes. Again, kind of the horse is out of the barn. By the time you get to weight change and symptoms, you are so close to a decompensation. You're so close to a hospital stay that really there's not time to turn the ship around. So what we need to do is find people here, not here. So how we do that, oops, hold on, where'd it go? There we go. How we do that is by using something called a Cardiomems. And this is what it looks like. It's very small. This is the actual device. These are the loops that just hold it in place when we place it in the pulmonary artery. It doesn't have a battery. It doesn't have to be plugged in. There's nothing to change. You put it in once and you walk away. So I'm very briefly going to talk about the CHAMPION trial. All of the slides are in there if you want to delve into it a little bit more. But this was the trial that looked at Cardiomems and monitoring the pressures to improve outcomes in New York Heart Association Class 3 patients. It's 64 US centers, so it's a pretty decent sized trial. So 550 patients, half in the treatment group, half in the control group. So the treatment group said, okay, I'm gonna talk to you about your symptoms and your weight. I'm gonna do all the things that we normally do. But then I'm also going to look at the numbers that I get from the Cardiomems and make decisions based on the numbers. Whereas the control group, they had a Cardiomems implanted, but they didn't get to look at the numbers. So they just treated based on the stuff that we've already talked about, weights and symptoms. Primary endpoint was heart failure hospitalization, and secondary endpoints were changes in PA pressures, number of patients admitted for heart failure, days alive, and quality of life. And I think really important about this is that quality of life was a metric. Usually we don't look at quality of life metrics, but I mean, how important is that for your heart failure patients? That's what they care about. If you look at the endpoint, the patients that we were able to look at their numbers and make decisions based on what their PA diastolic pressures were, had a 33% relative risk reduction in hospitalizations, which is pretty big. If you look at all of the secondary endpoints, quality of life was significantly better. Days outside of the hospital and alive were significantly better. Hospitalizations were significantly better. And change in baseline PA pressures were significantly better. And I'll get to why that is important in a minute. I want to look at a couple of the subgroup analyses just to show a couple of things. They actually broke out a group that they didn't ask symptoms or weights or anything. They only looked at the numbers. So what was the PA diastolic pressure? And I'm only going to make changes to my diuretics and my other medications based on what those numbers are. And just doing that alone gave you a 67% decrease in hospitalizations, which kind of shows that, you know, maybe we're not making the best decisions based on continuing to use symptoms as part of our decision-making process. And this was stunning to me. This was absolutely stunning to me. The other important thing to point out here is that this, as very few other things are, this is equally distributed between reduced ejection fraction and preserved ejection fraction. And it's really rare that we have things that affect patients with preserved ejection fraction. So here's reduced, and you can see there's a 43% reduction in hospitalization rates and a 57% reduction in mortality for reduced ejection fraction. So that's great. Love it. But let's look at preserved ejection fraction. 50% reduction, which is amazing in hospitalizations. 50% reduction. Number needed to treat is 2. I mean, we really have nothing else in our arsenal for preserved ejection fraction. I mean, every study that we've looked at has been negative. However, just using the numbers here is an amazing reduction in hospitalizations. So the take-home message about using this Cardiomems, and I'm going to show you a movie in just a second about how it goes in. The take-home message is that it significantly reduces 30-day readmissions, 78% reduction in 30-day readmissions, 58% reduction in all-cause 30-day readmissions, and a 49% reduction in hospitalizations using the Cardiomems. So the indications for use, there are only 2. Well, there are 2. You have to be New York Heart Association Class 3, and this is the big problem that we're having right now. Also, you've had to have had 1 or more hospital stays for heart failure in the last year. And so these 2 indications have really tied our hands. We would have a zillion patients that have these devices in, but, you know, what is a New York Heart Association Class 3? How do you define that? So in my view, the way I say that you're Class 3 is if you get symptoms when you're doing things in your house. So if you're walking from room to room and you get short of breath, you're Class 3. If you can mow the lawn, but you get short of breath, you're Class 2. And so, you know, finding Class 3 patients is a bit of a challenge. There's only one contraindication, and that's inability to tolerate antiplatelet therapy. This is the system. So you've got your sensor here. I'm going to show you putting it in. The patient lays on this pillow and it transmits the numbers. And it transmits the numbers to this Merlin program. I'll show you a little bit more as well. So this is implantation. I will show you.
The procedure is straightforward. A catheter is placed in the pulmonary artery to determine baseline hemodynamics and, along with a selective angiogram, to confirm the target implant vessel. The sensor delivery system is advanced over a guide wire to the identified target implant site. Once in position, the sensor is released from the delivery tool and its nitinol loops expand to stabilize it in the vessel. On average, the sensor occupies approximately 10% of the lumen and endothelializes within 3 months of implant. The Cardiomems PA sensor is calibrated during manufacturing. During the implant procedure, the sensor and PA catheter mean pressures are matched. After the implant procedure, the sensor provides accurate PA pressure measurements and is unlikely to require future adjustments.
So it's pretty simple. It's actually very quick, and that's why Dr. Rodriguez is not here. He's putting these in right now. We have 3 to put in today, so that's what's keeping him. So here is the PA angiogram that we do to try to figure out which vessel to put it in. So we're right here. Here's the dye that we just put in. You can see this nice branch of the pulmonary artery. It's about the right width, so this would be a perfect delivery site. Here you can see us delivering one. So you've got, here's your guide wire, and here is the sensor still on the guide wire. And then we've deep seated the wire down into that branch of the pulmonary artery. This is it after we have deployed it. So here it is sitting here. This is our right heart cath. Here's our balloon. Okay. And this is a picture of an actual patient. And here it is, right there. Okay, so let's look at our cases. Remember, our first guy was an ischemic cardiomyopathy, low EF, low ejection fraction, coronary disease, 3 hospital stays, on good medical therapy, your average comorbids. He's following with the heart failure nurses. This is what his numbers look like. So what you're looking at here, this is the PA systolic pressure. This is the mean PA pressure. And this is the PA diastolic pressure. Remember, the PA diastolic pressure is equal to the wedge, which is the filling pressures, which is your total volume, total body volume. So what you can see, these are daily readings. Each one of these little dots is a daily reading. Here you can see this has a note. So we made a change here. Looks like, I'm not sure exactly what change we made there, but we made a change there and we made a change here. But what I want to show you that's really telling about why this is important is down here. This is a graph that represents the entirety of time that this patient has had that sensor. So here was implantation. Pulmonary pressures were quite high. Following these and making adjustments to diuretics based on the numbers, we were able to drive that down. We drove it all the way down. So this patient now has lower pulmonary artery pressures, which is great, but it's really great because we know that we've really optimized their volume status, because lower PA pressures mean lower wedge pressures. Okay, so this was when we implanted. So the RA was 22, so very volume overloaded. The PA diastolic was 34, so the wedge was really high. And you can see that they correlate quite well, 34, 29, that's pretty close. Okay. These are just an example of the changes that we made based on the readings. So here we told them to take an extra torsemide. Here we reduced the torsemide. Here we reached our PA diastolic goal. And here we changed over to Bumex and made changes there. So here's our case 2. This is our preserved ejection fraction. And this is going to look very different. Okay, we know her story. So she's very brittle, very difficult to control her pressures. And you can see by looking at this graph, she's all over the place with her pressures. And so her PA diastolics are all over the place. You can see places where we've made changes. Here she's bumping up. So you can tell there's a note here. We increased her diuretic. Then she came down over here. So we decreased diuretics. And as you can see from this graph, that is the entirety of her time with the device. See how level we've made it? So it's not all over the place anymore. And she has not been hospitalized since implantation. And she was hospitalized like every other week. And here we have her implant value. So her PA diastolic was 23. And we've really been able to kind of keep it around 20. So 20 is not normal, but it's not bad. And it's certainly keeping her out of the hospital. These are just changes that we made based on those numbers. So I'm going to try to wrap up quickly here. In conclusion, this thing is great. It's amazing. It's wonderful. Everybody should have one. But everybody can't have one. And the reason why is because of those 2 criteria. You have to be New York Heart Association Class 3, and you have to have had a hospital stay. So the new directions here that you guys need to be aware of is that this is changing. So the GUIDE heart failure study is enrolling now. It's close to being ready to present the data, but hasn't been presented yet. And this is looking at everybody, class 2 to 4. You don't have to have had a hospitalization. You can just have an elevated brain natriuretic peptide. And who doesn't have that? They all do. It was a 12-month study, and the composite endpoint is cumulative heart failure events and all-cause mortality. And then all the secondary quality of life and functional assessments are part of that too. So the future implications are that we're going to have broader access to this modality that really works, decreased hospital stays, Medicare's happier, increased quality of life, and decreased mortality. So I think it's a win-win. I'm super excited about this technology, and I'm super excited about the fact that we're all going to be able to access this. And you guys can send patients to us, we can implant the patients, send them back to you. We can help manage the numbers. And at the end of the day, everybody wins. So thank you, guys.
Dr. Scott Tillery, we do have a question in the chat. It says, where the adjustments in diuretics based on the MEMS numbers followed renal function to make sure renal perfusion was not compromised. In studies, what percentage of patients were not able to tolerate diuresis? 2 out of 2 decreased renal function. I hope that I relate that question correctly. If there's any clarification, please feel free to come on mute. Abby, do you want to come off of mute or do you want to talk?
We can't hear anybody.
Don't get muted.
Abby's muted too. I'm just I can fix this. Did you change anything with your sound, KST?
Nope.
No. Okay. Dr. Grassi,
Yeah.
we can hear you if you can go ahead and ask your question.
So the question, I just wanted to know whether those adjustments in diuretics based on the MEMS numbers were, did the patient need to have any renal function follow-up to make sure that you were not compromising renal function? Because oftentimes when we diurese, we compromise renal function and people go into renal failure or acute kidney injury. And then on those studies that you referred to, what was the percentage of patients that were not able to tolerate that the MEMS, protocol because the renal function was compromised?
So that is actually part of the protocol that we use to figure out what goal number we need. So whenever we make changes in diuretics, we'll have them get a lab in a week, and that'll tell us where they are renally. And if they can't tolerate that dose and we're driving those numbers down too far, then we liberalize our goal. So, that's why some people have a goal. That's why everybody doesn't have a goal of 15, right? Because some people can't have a goal of 15. So some have a goal of like 22 or 23, because that's at that level, they're not in the hospital, they're not volume overloaded, and their kidneys are happy. I don't know the data on how many patients, have a higher goal, but I know that's my experience. And then there is also data, last paper that came out on, I can't remember the name of which guideline paper it was, came out with data about diuresing until you see a bump in creatinine is not a harbinger of long-term renal dysfunction. I thought that was an interesting paper, but yeah, you're absolutely right. I mean, so what we do is if we bump their creatinine and we show that they can't tolerate that goal, we liberalize the goal, we see the numbers come back down, and the patients generally do well.
Thank you.
Abby, did you want me to take you off of mute to ask the question, or are you able to come off of mute?
Can you hear me now?
We can, yes.
I'm not sure I had a specific question. I might have accidentally hit something that I didn't mean to. Just in general, I guess with nursing home patients, I have a couple in my head that I feel would be of benefit to this, but I think what makes it hard is trying to decide that New York class 3. Just with one patient in particular, she's morbidly obese and is wheelchair bound, so she's pretty limited and what she can do anyway. So it's very difficult to determine symptoms with her. And so how would something like that qualify somebody from that situation, or is that just an evaluation that needs to be done by cardiology?
So I think you're exactly right, and that is my big frustration as well. You know, being so tied up by this class 3, because I mean, are they class 3 because they have COPD? Are they class 3 because they're morbid obesity? Is it, you know, is it actual class 3 heart failure? It's so hard to know. So what we do is, you know, we do our best. We have some questionnaires that we give them, some quality of life questionnaires. You know, I ask them specifics about what they can and can't do and what makes them short of breath. And, you know, if they're limited, what are they limited by? Are they limited by knee pain, hip pain, muscle pain, or shortness of breath? And oftentimes you'll have someone who you think is class 3, but the more questions you ask them, they're really mostly limited by like orthopedic issues and things like that. So it's tough to do, and you've really hit the nail on the head. That's why I'm excited about this study coming out, that we don't have to do that anymore. So if they have an elevated BNP, boom, we're good. So that's exciting to me. The other thing that's really exciting to me is that this is finally something that treats heart failure with preserved ejection fraction, because there's really nothing treats it. And this is really exciting. And if we can take those patients, especially like the morbidly obese patients that are in a wheelchair, they don't move, they don't notice that they're filling up with fluid until all of a sudden they come in and they're in florid pulmonary edema, they can't breathe, but they don't have all those cues to show them along the way that they're failing. Those patients would benefit probably the most.
Yes, I agree. You just explained my patient to a T, and I would be thrilled if she could get this device.
Well, Cinder will evaluate her.
Oh, she has an appointment with you on June 2nd.
Oh, awesome. Okay.
Thanks.
Thank you, Dr. Scott Tillery. It was a great informative presentation, especially on the selection of patients and the benefit of remote monitoring. If everyone at RiverStone would like to get CME credit, they can complete the evaluation for CME that Carrie sent out. And thanks again for taking time to do your presentation.
No problem. Happy to help. Always happy to do whatever I can if you need me.
Thanks.
All right. Bye, guys.
Thanks, KST. Best one yet.